Good morning, all of you. Myself, Dr. Dvija Yagnik, Assistant Professor of the Parul Institute of Physiotherapy. Today, we have with us Dr. Ujala Patel. Ujala Patel is an Assistant Professor at SS Agrawal Institute of Physiotherapy and Medical Care Education. She finished her MPT in Cardiopulmonary Science and pursuing PhD from the PP Savani University in area of the same cardiorespiratory physiotherapy. She passed out MPT from that is Master of Physiotherapy in Srimad Rajchandra College of Physiotherapy, that is Ukata Sanya University. She is also alumni student of Parul Institute of Physiotherapy. She is also a certified aerobic and group fitness instructor, certified diet and nutrition instructor, and she is doing job as an assistant professor in SS Agrawal Institute of Physiotherapy and Medical Education since last was 1 year. Today, she is going to share her knowledge regarding the mobilization of ICU patient, a safety criteria with us. So, ma'am, you can continue.
Okay, thank you so much, Dr. Dvija ma'am, for this wonderful introduction. And good morning, all of you. I hope this session will be not a one-way session, it will be a two-way sessions, okay? So let's get started for this topic also, the mobilization of the ICU patients. What are the safety criteria that you have to measure, okay? First of all, when we go into the ICU, in our mind, we have to mobilize as fast, early as possible to the patients, okay? We mobilize patient first, okay? So we can reduce the ICU stay of the patients, okay? We reduce the another infection, chances of the infection, okay? So there is a lots of the indications of the early mobility. But when you do the mobility to the patients, what are the safety criteria that you have to mention during the patient mobilization? Okay, there is a lots of the adverse event happen during the mobilization, before a mobilization, as well as the after a mobilization of the patient. So what you might be a staff preparation, what might be a patient preparation, as well as what was the vital signs, what are the considerations that you have to maintain during the mobilization of the patient. So one by one we can check what was the precautionary measurement we have to see into the specially ICU patients. Okay. So what is mobilization? That we all know that what is mobilization? It is defined as the therapeutic, the perspective applications of the low intensity exercise in the acute ill patient. Generally in ICU, it is the intensive care unit. What was the patient? It a acute illness patient, and generally the patient may have a acute illness. So might be we have to mobilize this patient, but we have to go with the low intensity exercise first. Okay. So with the mobilization, what is the mobilization therapy? Okay, we can perform a low intensity exercise, and generally mobilization is performed into the upright position. So might be what are the upright position that we can conduct? It is a long sitting position or a sitting position, the standing position, as well as the walking. These three major positions are the mobilization position, and we can achieve into the patients. Okay, so one by one into the mobilization, how we can do the sitting position of the patient, how we can go with the standing position, and especially the walking, how we prescribe the walking for the patients, and what are the criteria you have to maintain during the mobilization of the period. Okay, so it is not it is not only the mobilization that you go with the ICU patient. Ultimately, with the patient, the staff preparation, what are the equipment that you use during the mobilization, it might be also have, and the staff already know it about the mobilization period. Okay, so you can see this image. Into this, you can see there is a patient in the intensive care unit, and this is the patient may have the ventilator support like this. Okay, this is the tubing. These are the staff support, and patient might be have a mobilized with all the attachment. Okay. So with this, we have to facility given to the patients as well as the hospital and the staff. You have to go with this preparation and go with the patient to the mobilization. And what are the safety consideration? We can go with this mobilization, that one by one we can see. So what is this aim of the webinar? You can attend this webinar. You can waste your time. You can given to this webinar. But what you have? What was the aim? The aim is that we have to recommendation. What are the safety parameters when you go with the mobilize your patient? First of all, what is mobilization? What is the mobilization in adult? What is the mechanical ventilator criteria? And it is intensive care unit patient. How you go with the mobilize to these patients? Okay, so we have a 4 consideration when we go with the mobilized patient. We have to go with the safety criteria in the 4 category. Okay, the first category, it is the respiratory consideration. The second one category, it is the cardiovascular consideration. Third one is the neurological consideration, and the fourth one, it is the other consideration. So one by one, we can go with all the considerations, and we can check what will the safety we have to provide to the patients. Okay, so first we go with the consideration. You know about the color coding. What is the color coding into the ICU, as well as safety parameters? What are the we have to see, especially for the vital sign. Okay. So in the ICU patients special, if you see a green color coding, if someone have to have you choose, or you have to say, or you hear that this might be have a green color coding. What is green color coding suggests in the traffic signal? We all know the green color coding. What is its signal? That your patient, it is on the low risk. Okay, low risk of the adverse event. Because what is the adverse event occur into the especially in the ICU? There is a, when you go with the mobilization, that might be a decrease into the blood pressure of the patient or increase into the blood pressure of the patient. There might be a patient may oxygen desaturation, or patient may have a breathlessness, or might be patient may have a cardiac arrest also. Okay, so these are the all the adverse event occur during the ICU mobilization of the patient. So there are the adverse event occur not, so we can go with this color coding line. Okay, so if you go with the green color, that means your patient, it is on the low adverse event. Okay, you can might be go with the walking also, you can might be go with the standing also. Okay, it is, you can go all the your ICU protocol, you can mobilize your patient in bed exercise also, as well as out bed exercise also. If there is a color coding like yellow, what is yellow color coding? That means your patient may have a moderate adverse event. Okay, your patient may have a moderate risk of the mobilization. You can mobilize your patient into the yellow coding line, but you have to prescribe your patients all the precautions you have to measure, as well as when you go with the out bed mobility, especially when you go with the walking in this yellow coding line patient, you have to see that your patient might be not into the fall formation, as well as all the equipment are attached with the patients, as well as you have to go with the some supervision, or the supervision or the medical officer have to supervise the patient during the yellow coding color of the mobilization of the patient. The last one is a red color coding. Okay, we all know the red color coding, it is into the dangerous color. Okay, if you can see or hear that the patient may have a red color coding, okay, at that time you cannot go with the mobility of the patient, especially in the outbed exercise, especially walking. You cannot prescribe into the red color coding line. Why? Your patient may be high risk of the have a adverse event. Okay, so if you see that your might be patient may have a red color coding line, you cannot go with the mobilization. Okay, so green color, you can go with the patient protocol, you can go with the walking also, outbed exercise also. The yellow color line, that means you can go with the superficial precaution, supervise the patients, as well as you have to might give a precautionary measurement you have to attach with your patient. Okay, and the red color line, you cannot go with the mobilized to your patient. So one by one, all the respiratory consideration, as well as cardiovascular consideration and the neurological considerations, we can check when we go with the red color line, when we go with the yellow color coding, as well as when we go with the green color coding. Okay. Yes. So the respiratory consideration. Into the respiratory consideration, we can see the intubation status of the period, what are the respiratory parameters, what are the ventilatory parameters, and what is the adjustive therapy. One by one, we can check this. Okay. So first, what is the respiratory parameter? Okay, we all know the normal respiratory rate. It is in adult, it is about 12 to 18 breaths per minute. But in the ICU patient, there might be an increase the respiratory rate of the patients. Okay, so if there is an increase the respiratory rate of the patient, when we go with the in-bed exercise and the out-bed exercise. Okay, so if the respiratory rate, it is about less than or equal to 30 breaths per minute. Okay, you can go with the in-bed exercise as well as out-bed exercise. It is a green color coding. Okay, but if the respiratory rate are greater than 30 breaths per minute, you can go with the in-bed exercise as well as out-bed exercise. Okay, but with the sufficient superficial observation of the patient, sufficient medical officer, you have to supervise the patient and especially the vital sign of the patient during the mobilization of the patients. Okay, in the outbed activity, you can check the respiratory rate of the patient. If there is some breathlessness patient may have, you have to stop the exercise, especially the outbed exercise. Okay, then what is the SpO2, the percutaneous oxygen saturation? If your patient may have a increase the greater than the 90% of the oxygen saturation, the normal range of the SpO2 is about greater than 95% in the normal individual. Okay, but in the ICU patient there might be a decrease into the oxygen saturation. It is about the below the 90 as well as 90 also. If your patient may have a criteria about the SpO2, it is about greater than or equal to 90%, you can go with the in-bed exercise as well as out-bed exercise. It is a green color coding line, you can go with the patient exercise. Okay, but if there might be a SpO2, it is about less than 90%, what you can do? In-bed exercise, you can go with the superficial medical support. Okay, you have to during the in-bed exercise also, if there is a less than 90%, you have to check the patient SpO2 throughout the exercise. Okay, if there is a dropping into the SpO2, you might be you go with the precautionary measurement first. Okay, so during the in-bed exercise, you can go with the 90%, decrease the 90%. If you have to go with the outbed exercise, you cannot go with the outbed exercise, like you cannot prescribe the long standing to the patient, you cannot prescribe the long walking to the patient. If the patient saturation it is about the less than 90°, you cannot go with the outbed exercise, because in the outbed exercise we all know that the patient may need the amount of the oxygen is high when you go with the walking. So if there is a you go with the outbed exercise, that might be adverse event occur and the patient may go into the oxygen desaturation. Okay, so at that time you have to not go with the outbed exercise. Second one is the mechanical ventilator. In generally, whenever you go into the ICU patient, intensive care unit patient, there might be a chances that your patient it is on the ventilator support. Okay, so in the ventilator there are some mode or some parameters that we have to set. Okay, so first parameter, it is about the fraction of the inspired oxygen. What is the fraction of the inspired oxygen? How much percentage of the oxygen you have concentrate in your lung? It is the fraction of the inspired oxygen. In the normal individual, it is about 21%. Okay, but into the ICU patient, when we go with the mechanical ventilator, the FiO2 we have to set. The 50% of the FiO2 it is normal, and you can go with the in-bed exercise as well as out-bed exercise. When you go with this ICU patient, and if the FiO2 it is less than or equal to 60%, up to 60% we can go, and in-bed exercise as well as out-bed exercise you can prescribe your patient. But it is greater than 60%, that means your patient may require more oxygen. Okay, more percentage of the oxygen. So at that time you can go with the in-bed exercise as well as out-bed exercise, but with the yellow color coding. That means you have to go with the precautionary measurement. You have to throughout the exercise, in-bed exercise or out-bed exercise mobilization, you have to check the patient oxygen saturation level. Okay, if it will be a decrease, you have to stop the mobilize of the patient. Then the PEEP. What is PEEP? It is a positive and expiratory pressure. Okay, the positive and expiratory pressure, generally what it's cause, it will be a increase the intrathoracic pressure of the patient. If there is an increase the intrathoracic of the pressure, it might be the patient might be go into the postural hypotension. Okay, so if there is a less than or equal to 10 centimeter H2O, you can go with the in-bed exercise as well as out-bed exercise. But it is increased than the 10 centimeter H2O. Okay, you cannot go with this exercise with the precautionary measurement, and throughout the exercise you have to check the patient hypertension. Okay, blood pressure. If your patient may have a blood pressure or it might be a hypotension, your patient, you have to check during the exercise as well as mobilization of your period, that your patient blood pressure might be not the decrease during the mobilization, especially outbed exercise. Then the mode. What is the mode of the HFO? It is a high frequency oscillatory volume. Okay, when you go with this, when the high frequency oscillatory ventilator or volume, it is a one type of the lung protective mechanism. You can go when it will be prescribed when your patient may have a high oxygen saturation or your patient may have a high demand of the oxygen saturation. Okay, So it might be like that your patient may have increase the tidal volume. Okay. So is the what is this mode have to prescribe the respiratory rate of the patient? It will be higher than the 3 times. Okay, and the tidal volume are decreasing into this mode. So when you go with the outbed exercise first, so at that time your patient might be have a mobilized. Okay, and patient might be have a tidal volume increase. But into this mode, the tidal volume may be a decrease into this mode specially. So you cannot go with the outbed exercise when you prescribe the mode high frequency oscillatory ventilator. As well as in bed exercise, you have to go with it, but you have to check the patient's first criteria and supervise the patient, especially the oxygen saturation when you go with this mechanical ventilator patient. Then the intubation period of the patient. Intubation, it is a one type of the process when you go with the your patient with the test the mechanical ventilator. You can see one tube. It will be attached into the oral cavity, also into the nasal cavity, or sometimes the tracheostomy will be done. It will be like here. Okay. So if your patient may have go into the intubation period, the tube will be inserted into the patient for the oxygen purpose. Okay, oxygen, it is a one type of the part of the oxygen therapy. So into the endotracheal tube as well as into the tracheostomy tube, you can go with the in-bed exercise as well as out-bed exercise also. But you have to check that all the tube connection, whether it is endotracheal tube or a tracheostomy tube, all the tube and all the tube are attached well with the ventilator support or the ventilator machine. There might be not the dislocation of all the tube when you go spatially into the outbed exercise. You have to check all the lines and all the connection are connected very well. There might be not the dislocations or disconnection of the any tube when you go with the mobilized to your patients. And the rescue therapy. What is rescue therapy in ICU? When we go into the ICU, where we all know that the patient may have some pharmacological effect, or some patient may have on the drug effect. So on the drug, there might be some drug. It is a vasodilator drug. So these are especially the nitric oxide. It will be given into the respiratory failure patient. So what these drugs might be doing into the body, it is the vasodilator drug. So when we prescribe or when the patient have receiving the vasodilator drug, at that time your patient may have a decrease into the blood pressure. Okay, so we all know in bed as well as out bed exercise you can prescribe to this patient, but you have to check continuously the blood pressure of the patient. If there is a dropping into the blood pressure continuously about 2 to 3 minutes, when you go especially the out bed exercise and you check that there is a drop into the blood pressure about every 2 to 3 minutes, you have to stop the patient exercise. If there might be a not decreasing into the blood pressure, patient receiving vasodilator, and you go with the outbed exercise specially, and at that time you have to measure a blood pressure of the patient. It will be not the decreasing with the supervision or the precautionary measurement. You can go with the outbed exercise, but your patient may have the moderate rate. So you have to check the blood pressure during the outbed exercise specially. Okay. Now the cardiovascular consideration. I hope everyone is know about what is the respiratory parameters, what are the respiratory rate, what are the ventilatory supports we have to do, as well as what is the rescue therapy, what were the pharmacological effect occur onto the patient body. Now the cardiovascular consideration. So into the cardiovascular consideration, we can check about the patient blood pressure, cardiac arrhythmia, and the presence of device. Okay, so one by one we can check the blood pressure. We all know the normal range of the blood pressure. The systolic it is about 120 and the diastolic it is about 80 mmHg. Okay. When we go with the hypertension, when there is a increased the blood pressure, the range it is about increased 140 mmHg of the systolic blood pressure. It is called the hypertension, and it is increased diastolic about 90 mmHg. It is called the patient may be hypertensive stage 1. So when the patient may have an early diagnosis with the blood pressure and patient are receiving the IV line, okay, first the drug induced, it is the oral induce of the drug. But with the oral induced medicine, patient may not reliable. A patient may not progress very well. So what was the second route of the drug line? It is the IV drug line. Okay. So when the intravenously antihypertensive drug patient are receiving, At that time, you cannot go with the in-bed and the out-bed exercise. It is contraindicated for the patient. It might be a increase the patient blood pressure level. Okay. So with the patient who have on the emergency department and receiving the anti-hypertensive drug via the IV line, you cannot go the patient mobilize. Okay. It is contraindicated. Second one is the MAP. What is MAP? It is mean arterial blood pressure. Okay. So it is the summation of the both the systolic and the diastolic blood pressure. It is the average of the systolic and the diastolic blood pressure. The normal range of the mean arterial pressure, it is about the 70 to 100 mmHg. Okay. So if your patient may have a below the target range causing symptom, that might be what is the below the target range, that we know that the mean arterial blood pressure, it is 70 to 100 mmHg. So below target range, it is about 70 mmHg. If your patient may have a below target range, that means less than 70 mmHg, patient may have a mean arterial blood pressure and your patient causing symptoms. What are the symptoms? Symptoms like cold hand, symptoms like your patient may have a absent or decrease the peripheral pulses. Okay, at that time you can go with the in-bed exercise with the precautionary measurement. Okay, you have to check the mean arterial blood pressure not dropping so much when you do the in-bed exercise. What about the out-bed exercise? In the out-bed exercise, if there is a absent of the peripheral pulses, you cannot go with the out-bed exercise. Okay, then it is a greater than the lower limit. Okay, we all know the lower limit is about 70 mmHg. Okay, it is greater than the lower limit. That means it is increased greater than the 70 mmHg of the lower limit, and your patient may have a receiving no drug or a low drug support. It is like if your patient have a hypertensive and your patient receiving 10 mmHg of the dose of the hypertensive drug. So this is a low drug support or a low dose of the support. So at that time you can go with the in-bed exercise as well as the out-bed exercise. But if there is your patient may have a greater than lower limit and your patient may have a moderate drug level, it is like your patient may have a receive a 50 mmHg of the drug. So it is a moderate drug dose. So at that time you can see that it might be a yellow color coding line. That means your patient may not go. Your patient may go with the in-bed and out-bed exercise with the precautionary measurement. You have to continuously check the patient mean arterial blood pressures. Okay. Then if it will be a greater than the lower limit, it is greater than the 70 mmHg. And the patient receiving the high drug support, it is like your patient may have a receiving 100 mg of the drug, high level of the support of the drug, you can go in bed exercise. Okay, yellow color coding line, while you have to precautionary measurement, you have to check the mean arterial blood pressure of the patient. If the patient go into the out-bed exercise, it is contraindicated when the patient receiving the high drug support. Okay, then if the patient is suspected or known of the pulmonary hypertension. What is the pulmonary hypertension? When the patient may have a pulmonary hypertension, there might be a cardiac workload may be increase. So when you go with the in-bed exercise, you have to take some precautionary measurement, but in the out-bed exercise, it is contraindicated because during the mobility, especially in the walking, your cardiac workload may be increased. Okay, and in the pulmonary hypertension, already the patient may have lots of the cardiac workload. So at that time, you cannot go with the out-bed exercise first. Okay, so it are the contraindicated. Now the cardiac arrhythmia. If your patient may have a cardiac arrhythmia, so generally the cardiac arrhythmia, we can see the bradycardia and the tachycardia. We all know what is the bradycardia. It is decreasing into the heart rate about 60, less than 60. Your heart rate may be known as the bradycardia. If your patient may have a bradycardia and your patient may on the pharmacological treatment, or there is a chances of the emergency pacemaker insertion in the emergency department. At that time, if your patient may require pharmacological treatment or the pacemaker is inserted, you cannot go with the in-bed as well as out-bed exercise. It will be a contraindicated to patient. If your patient may have a bradycardia, but there is a not require of the pharmacological treatment, that means your patient not that much of the critical. Okay, so at that time you can go with the in-bed as well as the out-bed exercise, but you have to go into the yellow color coding line. That means you have to continuously measure a patient heart rate during the in-bed and especially out-bed exercise also. Now the tachycardia. What is the tachycardia? That we all know that increasing into the heart rate. Okay, when there is an increasing into the heart rate, the normal range of the heart rate, it is about 60 to 100 beat per minute. If there is a patient may have a tachycardia, that means there is an increase into the heart rate. It is greater than the 100 beat per minute. At that time, it is known as a tachycardia. If there is a tachycardia, the ventricular rate, it is about 150 beat per minute. At that time, you can go with the in-bed exercise with the precautionary measurement. You have to continuously measure on the monitoring system of the patient, and you have to check the patient heart rate. Okay, in-bed exercise. But in the out-bed exercise, it is contraindicated. You cannot go with the out-bed exercise. If your patient ventricular rate, it is about 120 to 150 beat per minute, you can go with the in-bed exercise, also out-bed exercise. But with precautionary measurement, you have to continuously check the patient heart rate during the walking, especially in the out-bed exercise during the walking period time. When the ventricular rate, it is about less than 120 beat per minute, you can go with the in-bed exercise as well as out-bed exercise also. When you have to go with, you can go with is less than 120 beat per minute. Okay, now the device, what are the sometimes in the ICU there is a lots of device that will be attached with the patients. Okay, so what are the cardiac device that have we attached with the patient? Generally the femoral IABP. Okay, it is a femoral. What is femoral IABP? It is the intra-aortic balloon pump. Okay, into this figure you can see it is the IABP machine. It is the intra-aortic balloon pump. It is a one type of the machines. Okay, it will be a given when there is a left ventricular heart failure. Okay, it might be, it is a same like the mechanical ventilator machines. Okay, what occur doing into this machine, there is a one catheter that will be a insert from the femoral artery, and one guide wire or the catheter, it will be a go like this from this, and it will be a go from the through the aorta, from the femoral artery to the your ascending aorta. Okay, to improve the aortic ventilation. So what into this do, when the patient may have a femoral IABP, okay, inserted via the femoral artery, at that time in-bed exercise, you can go with the in-bed exercise, but you cannot go out-bed exercise. But when you go in-bed exercise also, you have to take some precautionary measurement that you might be not go with the hip flexion of the patient, because if there might be a hip flexion of the patient, the kinking of this femoral artery may happen, and the aortic compensation may have that. Okay, so at that time you cannot go with the hip flexion. You can go with the alternatively exercise also. You cannot go with the hip flexion when you go with the femoral IABP. And the outbed exercise, it is totally contraindicated. You cannot you cannot prescribe walking or long standing to your patients. Okay, then the ventricular assisted device, it is the one type of the device. It is looking like this. Okay, it is given when there is a left ventricular failure, or when there is a heart failure. If the patient may have a requirement of the heart transplant, and there is a occurred the surgery. Okay, so at that time this is the surgery or the device you can go with attached like this might be have a battery on this, and this is the heart body. Okay, it will be a ventricular device. It will be attached with the patient. In this, if the patient may have a ventricular assisted device, you can go with the in-bed exercise as well as the out-bed exercise. There might be a not the risk criteria. Okay, if your patient may have a pulmonary artery catheter, okay, this is the pulmonary artery catheter. You can see, okay, it will be a measure the cardiac output of the patients. Okay, stroke volume of the patient. Lots of the measurement we have taken with this pulmonary catheter. Okay, so if your patient may have a pulmonary catheter or another cardiac outputting monitoring device, you can go with the in-bed exercise, but you cannot go with the out-bed exercise. Okay, you can go with the out-bed exercise, but when you have to some precautionary measurement, you have to take that this location of the pulmonary catheter, it not happen during the out-bed exercise. There might be a compression of the pulmonary catheter also. So when you go with the out-bed exercise, you might be have to check that you have to take a precautionary measurement that there might be a not the disconnection of the pulmonary artery catheter. Now the another cardiovascular consultation is when with the patient it is into the shock. Okay, shock might be have a symptoms like if the patient may have like the severe infections, and your patient may have a sudden drop into the blood flow. So these are the some symptoms of the shock. Okay, if your patient may have go into the shock and any causes with any causes, okay, and the lactic formation with greater than 4 mmol per liter. Generally, the lactic formation it is less than 2 mmol. The normal range it is about 2 mmol per liter in the lactic formation. We all know the lactic it is a byproduct of the anaerobic system. Okay, if there is a lactic formation of high in the report, that means your patient may get fatigue earlier. Okay, so you can go with the in-bed exercise and out-bed exercise with the precautionary measurement. During the mobilization, you have to check the patient SpO2 as well as patient facial expression also. If your patient might be fatigue early, you have to give the rest to your patient and go with the exercise, especially the out-bed exercise. Okay, you have to go with the precautionary measurement. If you have to known or suspected the DVT or the pulmonary embolism, okay, if there is a if the patient may have a pulmonary embolism and if you suspected that your patient may have a pulmonary embolism, okay, so first what you have to check, you have to check the PT-INR report. What is PT-INR report? It is a prothrombin time and international normalized ratio. Okay, so it might be the normal range of this PT-INR report. It is about the normal range 10 to 12 seconds. Okay, for the blood clotting. Okay, so normally what happens if you are suspected that your patient or you've known that your patient may have a DVT or pulmonary embolism, at that time you sure that your patient may have on the anticoagulant drug as well as your patient may have receiving the anticoagulant therapy. At that time, at this all the precautionary measurement you can check and you can go with the in-bed exercise as well as out-bed exercise with all the precautionary measurement and the medical supervision. Okay, if there is some breathlessness patient may have or a giddiness, you have to stop the exercise. So during the mobilization you have to go with all the precautionary measurement. So if there is a known or a suspected the aortic stenosis, okay, in bed exercise as well as out bed exercise you can go, but out bed exercise you can go with the precautionary measurement because the cardiac load may be increased during the aortic stenosis. If the patient may suspected about the cardiac ischemia, if your patient in bed exercise you can go. If your patient may go with your patient may tell that they might be have a pain into the chest pain, upper back, okay, or the chest discomfort or breathlessness, okay, giddiness, like these symptoms if your patient may have, with the precautionary measurement or a low intensity exercise you can prescribe into the in bed exercise and continuously measure the patient heart rate spatially during this in bed exercise. Okay, if your patient go with the out bed exercise, it is totally contraindicated. You see the ECG report of the patient. If there is a depression of the ST segment, okay, about the 2 greater than the 2 mm, you cannot go with the especially the out bed exercise. Okay, and you have to check the all the precautionary measurement when you go with the in bed exercise also. Okay, now what are the neurological consideration that we can see? Okay, so first we have to see the level of the consciousness of the patient, then the intracranial pressure of the patient. Okay, so how we check the level of the consciousness of the patient into the ICU. Okay, so there might be some scale, the RSS scale. It is a Richmond Agitation Sedation Scale. Okay, so what this scale is measured and how its scale is measured. Okay, in the specially ICU, that might be a patient may have on the sedation. Okay, so at that time you can check this scale. What is the criteria of your patient? So this score or the scale have a 10 point. Okay, it will be starting from the -5 and it will be ending from the 4 plus. Okay, so the -5, what is -5? It is indicate that your patient may have a not responding or your patient may have a comatose or unconscious. Okay, what is 4 plus indicate that your patient may have a combative. Combative means your patient is very violent, where patient might be fighting with your youth with the staff member. Okay, your patient is your staff member also in the danger when the patient is combative. Okay, so it is the 4 plus. Okay, and what is 1, what is 0? It is your patient may be alert and calm. Okay, so into where you can see the green line 0 to -2. That means your patient may have a light sedation. In the -1, your patient may have a drowsy phase. Your patient may have a alert and give you response in the light sedation. Your patient may have a awake and give you your response. Okay, so into 0 to 2 minus 2, you can go with the in bed and out bed exercise with the precautionary measure bed, but you cannot go with this if your patient may have a greater than 2 this scale, you cannot go with these patients. Okay, so if your patient may have a drowsy or your score, RSS score, it is about -1 to 1 plus. In bed exercise and out bed exercise, you can go with it. If your patient may have a lightly sedated, that means -2 or a 2 plus, you can go with the in bed exercise and out bed exercise. That your patient might be not the fall, you have to that this fall might be less, you have to check on this in bed and out bed exercise also. When you go with the patient have a deeply sedated, that means the RSS score, it is about less than or a -2. Okay, you can go with the in bed exercise also, and but you cannot go with the out bed exercise. Is the RSS score, it is about greater than 2 plus. If your patient may have a combative and like that, so you can go with this in bed as well as out bed exercise. It is totally contraindicated into the RSS greater than 2 plus when you have to score like this. Okay, second one is the ICP. Okay, if this a patient may have a intracranial pressure increase. Okay, if there is a when the intracranial pressure may increase, when there is a brain tumor of the patient, when there is a cerebrosinus fluid may be increased. Okay, if there is a patient may have a hydrocephalus, so at that time yeah, the intracranial pressure might be a increase. Okay, so if there is a intracranial pressure might be increased, at that time you cannot go with the in bed exercise as well as out bed exercise. Okay, so the normal intracranial pressure, it is about 5 to 50 mmHg. If there is an increase into the intracranial pressure than the 15 mmHg, you cannot go with the in bed exercise as well as out bed exercise. The other neurological consideration, like if the patient may do the craniotomy, have a craniotomy, you can go in bed exercise, out bed exercise with the precautionary measurement. If there is a open lumbar drain, okay, if there is it will be a one procedure done into the for the cerebrospinal fluid. Okay, it will be a one a tube inserted into the spinal level. Okay, and it will be a go into, you can go with the in bed exercise as well as out bed exercise. You can go in bed exercise, but you cannot go with the out bed exercise, especially into the lumbar drainer patient. Okay, if the patient may have acute spinal cord injury, you can go with the in bed exercise, but you can go not you can go with the out bed exercise with the some precautionary measurement. If your patient may have an uncontrolled seizure, you cannot go with the in bed as well as out bed exercise. It is totally contraindicated with the patients. Okay. So now we will talk about the other consideration, like including line, external device, what was the surgical and the medical conditions. Okay. If the surgical conditions like unstable fracture, pelvis fracture, spinal fracture, or lower limb fracture, especially a femur fracture, in bed exercise you can go with the precautionary measurement. Okay, but you cannot go with the out bed exercise. If there is a large or a open wound, you can go with the in bed exercise, but you cannot go with the out bed exercise also. It might be a active bleeding start when you go with the out bed exercise. If you go for the walking in the large open wound, that might be a chances of the bleeding when you go with the out bed exercise. So it is contraindicated when you go with the out bed exercise. So second one is the some medical condition, like if the patient may unknown uncontrollable active bleeding, okay, might be occur, when at that time you cannot go with the in bed exercise as well as out bed exercise. It is totally contraindicated. If your patient is on the active hypothermia management. Okay, if your patient may have a fever, if your patient may have a greater than 100 Fahrenheit of the hypothermia. Okay, at that time you can go with the in bed exercise and out bed exercise with the precautionary measurement. You have to go with the during the exercise, you have to check the patient temperature, because when the hypothermia occur, when the increase into the temperature. Okay, so the metabolic activity of the body, it ultimately increase. So when you go with the in bed and out bed exercise, it might be a increase the metabolic activity further. So at that time, in the hypothermia patient, you have to check during an in bed and out bed exercise patient temperature first. Okay. So another consideration, like if the patient may have a ICU weakness. Okay. Some of the patient may have ICU weakness, like patient may have go with the atrophy also. Okay. So into this, you can go with the in-bed and out-bed exercise. If the patient may have a venous or an arterial catheter, at that time you go with the in-bed and out-bed exercise. If your patient may have a femoral sheath, okay, in-bed exercise without hip flexion, you can go with this exercise, but you cannot go with the out-bed exercise. And the other attachment like the nasogastric tube, central venous catheter, wound drain, okay, intercostal catheter, urinary catheter, if all are attached with the patient, you go with the in-bed as well as out-bed exercise, but you have to check that all the equipment are attached well while the out-bed exercise specially, okay? There might be not the disconnection of the any attachment. Okay, so these are the all the criteria. Okay, so now what are the safety criteria? What are the safety criteria we have to manage and how we manage the mobilization, especially the out-bed mobilization of the patient. So first you have to checklist. Okay, what is the how we prepare the patient for the mobilization. What is the preparation of the staff of the mobilization, what was the safety during the mobilization we have to take, and after the mobilization what we have to check or what we have to do. Okay, first of all, the preparation of the mobilization, okay, it is include the patient preparation, staff preparation, and the equipment that may be attached during the mobilization. Okay, so first it is the patient preparation. Okay, so how you prepare your patient? First, you have to explain all the procedure to your patient. What is mobilization? What is the benefit as well as what adverse event occur during the mobilization? Chances of adverse event occur during the mobilization, and gain the consent from the patient first before the mobilize your patient. Okay, current fall risk. If there is a current fall risk, you have to check first that. Okay, and all the physiotherapy assessment vitals you have to take first, and if there is a need of the airway clearance technique, you have to go prior to the mobilization. Then you have to go with the non-sleepy shocks because there is a chances of fall during the especially outbed exercise, walking exercise. At that time there is a chances of fall into the patient. So at that time there is a non-sleepy socks might be there for the patient, as well as enclosed footwear will be to reduce the hospital acquired infection, chances of reduce of hospital acquired infection. So we can enclose the footwear for the patient and minimize the attachment. All the attachment, like some attachment are not necessary during the mobilization. Like if your patient on the IV fluid line, okay, at that time you can disconnect it, this attachment, and you can go with the mobilize your patient. So minimize the attachment first. And if your patient may have attached all the invasive line, if you have to check that it might be ensured that all the invasive lines are well secure when you go with the mobilize to your patient. What are the staff preparation? Okay, but how many number of staff are required during the assessment? First, you have to assess what was the patient stability, what are the fall criteria. Okay, so you have to check that first, and how many staff you have to necessary during the patient mobilization. Okay, so you have to discuss the duration of the mobilization. Okay, how many time it might be a 2 minute, 3 minute, 4 minute, 5 minute. Okay, so you have to discuss the duration of the mobilization, as well as some facilities are available when you go with the mobilization, because in the mobilization, especially in the walking, there might be a chances of the patient may go into the drowsy stage, or your patient may go into the oxygen desaturation, as well as some connection are maybe a compromise or a dislocate or a disconnected. So at that time, what you have to do, what was the facility you have to have, what was the modality or the machines you have to have on the patient side, you have to go with all the through this. Okay, and what are the equipment you have to need for this. So check first the safely weight of all the equipment. Sometimes the equipment are too heavy, so you might be need the trolley. Okay, you can check into this figure. There might be some equipment are attached with the patient, especially the ventilator. You can see this. Okay, so there might be you need a trolley for other equipment. Other equipment who may be connected with the patients. Okay, chair for the transfer. Okay, you can see into this. There might be a wheelchair behind the patient. Okay, for the patient transfer, if your patient may during the mobilization, your patient may have a fatigue you can go with the rest period on the chair. Okay, walking frame, if your patient may have a like this is the walking frame you can provide to your patient for the assistant purpose. Okay, and emergency equipment also. You can go with the portable oxygen or ambu bag as well as defibrillator while the mobilize the patient, especially if your patient you're going into the yellow color coding line, you have to check the emergency equipment first. Okay, so these are the some mobile equipment, the ventilator, ambu bag, portable oxygen, portable suctioning, monitoring, okay, portable chair, IV pole. These are all the equipment you have to require during the mobilization. And lastly, you have to check that if the walking route are clear or not. Okay, sometime in ICU there might be a emergency cases, so at that time the walking route might be not the clear. So before the mobilize your patient, you have to check the walking route are clear or not. That might be your first criteria when you go with the mobilize your patient. What you have to do during the mobilization? For the patient and staff, you have to check the ongoing communication with your patient. If there might be some patient may have some discomfort, if your patient may have some chest discomfort, or patient may have some giddiness, or patient may have a breathlessness, you have to communicate with your patient about the patient tolerance level. Okay, assist your patient with the tolerance level, or the on the second day of the ICU or patient tolerance level, your patient may mobilize or walking for a 1 or a 2 minutes. On the second day, they might be mobilize your patient. It is about tolerance level, maybe increase. It might be a go with the 3 minutes also. So you have to assess your patient tolerance level. Sometimes patient may tolerance level may decrease also. You have to check the assess your patient tolerance level also, and the ongoing communication you have to check with your patients. Okay, and equipment environment, monitoring all the invasive lines are attached with the patients. Okay, monitoring all the equipment when you go with the mobilization, all the vital signs especially you have to check when you go during the mobilization. What you do after a mobilization? Okay, if your patient may have you have to settle back your patient for the rest position. Okay, evaluate the tolerance level and what was the response of the mobilization. Okay, ensure that all the lines, all the monitoring system, all the line beside the monitoring system are you reconnected very well. Okay, you have to ensure this. All you have to check first this. Okay, and the staff, you have to do the mobility status of the patient and the measure the vital signs of the patient after a mobilize also. Okay, and all the things are documented. What was the equipment are used during the mobilization? You have to check it to the patient criteria. If there is some adverse event occur during the mobilization, like your patient may have a fall, your patient may have a desaturated. Okay, so all are the adverse event occur during the mobilization. So at that time, if some event occur, you have to report into your senior or medical officer, as well as you have to document it into the file when you go with the after a mobilization. Okay, and what was the before a mobilization, what was the vital signs of the patient, as well as after a mobilization, what was the vital signs of the patient, you might be noted into the patient or as well as. Okay, so these are the after line. I hope it will be clear with the all. There might be some cases. So with the some student, you can identify whether you go with the mobilization of your patient or not. This is the case 1. So the respiratory rate, it is about 30 beat per breaths per minute. Heart rate, it is about 150 beat per minute. Patient may have a femoral IABP, intra-aortic balloon pump. Patient may done with the craniotomy, and patient may have a diagnosis with the uncontrolled active bleeding. So what you can do? You can go if there is a green color coding, yellow color coding, or the red color coding. And according to you, what you can do? You can go with the mobilize your patient or not. Can anyone answer? Am I audible?
Yes, ma'am, you are audible. But the thing is it is on Facebook Live, na? The students are not able to answer.
What,
Like
ma'am?
the students are not able to answer because it's on FB Live, Facebook Live.
Okay, okay. So it is like that your patient may have the respiratory rate, it is about greater than 30 breaths per minute. The heart rate, it is about greater than 50 beats per minute. And there is a femoral IABP. Okay. So you cannot go with the hip flexion. In the craniotomy, you can go with the in-bed exercise, but patient may have uncontrolled bleeding. Okay. So it is the totally red color coding of the patient. You cannot go with the in-bed as well as out-bed exercise of the patient. Okay. So this is the case 2. Okay, the patient may have a respiratory rate about 20 rate per minute. It is less than 30. Okay, the patient may have a heart rate. It is about 150 beat per minute. It is less than 120 beat per minute. The FiO2 it is about 50%. It is less than 60% also. The lactate formation, it is about greater than 2 mmol. Patient may have a ICU acquired weakness, intercostal catheter, and the spinal cord injury. Okay, so if patient have a spinal cord injury, you have to go with the precautionary measurement. But all the criteria are going into the green color coding line, so you can go and you can mobilize to your patient first. Okay. So what is the conclusion of this webinar? According to this, we can implantation of this recommendation has the potential to maximize the early mobilization. Okay, you have to maximize the early mobilization while minimize the risk of the adverse safety event. Okay, with the all the equipment are attached with the patients. Okay, with all the staff member, we have to reduce the risk of the adverse event when you go with the mobilization of the patient. It might be improve the functional outcome of the patient. It might be reduce the ICU stay as well as hospital stay of the patient, and it will be improving the patient condition further. Okay, so whenever you go with the in ICU patient, you have to check first the patient all the vital sign, what was the device attached with the patient, what was the green color line, what was the yellow color coding line, and what was the red color coding line. You have to check whenever you go into the ICU before a mobilization as well as during the mobilization, what you have to do as well as after a mobilization. I hope it will be a great session and you might be knowing something new, and thank you so much. Yes, ma'am. Yes, ma'am. Dvija, ma'am.
Hi, yes, hello.
Yes, ma'am. So,
Okay.
anyone have any question?
Okay, so as I found there is no questions. Thank you so much, Dr. Ujala, for sharing this wonderful knowledge
Okay.
with us.
Thank you, ma'am.
Thank you so much. So we can conclude the webinar.
Yes, ma'am.
Hello.
Huh, ma'am.
Okay, thank you so much for sharing your knowledge with us, Dr.
Yes.
Ujala.
Thank you so much, Parul University, to giving me this opportunity to share my knowledge. Thank you so much, Dr. Dvija, for supporting me, and especially thank you so much all the staff members, especially the Dr. Diditi ma'am and Chetali ma'am. Thank you so much once again, Dr. Dvija. Thank you.
Thank you.